Ketamine was developed in Vietnam in the early 60s. It was a dissociative anesthetic that could be injected into shocky wounded soldiers to get them back to the MASH, the medevac hospital. And so people carried around syringes of ketamine. And so when somebody was injured, shot, they would be injected. Medevac would be called in. 20 minutes later, they would be transferred back. They would wake up 45 minutes later, and no cardiac or respiratory suppression with the drug as it was developed. Many people did report that they had these odd psychedelic experiences. Nobody made much of those until much later into the 1980s and 90s when they began to do research. And what they found out was that the psychedelic experience itself was some sort of healing process. That carried forward. And so for the next 20, 25 years, they were looking at it in regards to depression, PTSD, suicidality. And it was never declared a class 1 drug. It was kept at a class 3. So it's something akin to a narcotic, Tylenol number 3, for instance. So, I mean, it's relatively available. But the thing is that the way that I treat it, use it, dispense it is with the greatest of care. But the most important thing that I think that happens in this whole process is that there is a container that Jung and the depth psychologist talked about transference and countertransference. That's between the patient and the physician. There's an exchange that goes on there. Quantum mechanics tells us that we're all just these probability fields, and that's true. I mean, I've seen this time and again in this space. But as long as we are able to constellate a safe container, and I do some intentional work with the patient. We do a little prayer to start with, to invoke the sacred, whatever shape, form, or fashion they carry. Then, when the effect of the medication then comes in to this container, I'm conscious of the fact that it's active. It's a psychoactive process. It's a psychedelic. It moves into the system, into the aura, into the body of the patient, and the work is done between Metis and the patient. And at a certain amount, at the amount that I give, it's not a general anesthetic dose. It's not a party dose. It's in a correct formulation that pretty much guarantees that this psychedelic experience will happen in some shape, form, or fashion. The patient then lies down. I watch them for the next 40 minutes or however. Some people as short as 20 minutes, some as long as an hour and a half. But and some talk intermittently, some ask for reassurance. But it's such a safe medication. It's such a safe drug to be administered in this way that I've just not had any problems with that. Now, if there was, then I do the standard. I know how to administer CPR and things like that. But I've just never run into that. And in the literature, ketamine used in this way just is the safest med that you could think of, mainly because of the way that it was developed and what it was developed for, shocking soldiers on the battlefield to get them transported without putting them in any more duress. But So people come through that and they wake up after about 45 minutes, and that whatever happens in that 45 minutes is between Metis, between that consciousness and the medication and the person. And it always seems, or it typically seems to find whatever level that needs to be worked on. So whether or not that is something in the conscious realm or unconscious, Metis seems to open that up. And so what I typically hear when people come out of that is, I feel lighter. I just feel lighter. If they're suicidal, if they were suicidal moving in, that's the one thing that I can pretty well say is just taken off the top from the very beginning. It is a medication that I would not hesitate to use with loved ones. And especially in that setting, if the thought of suicide is even a small part of the picture, this provides some really concrete intervention that we just haven't had before, and the studies show that.